I'm Shawna Robbins, founder and CEO of Third Spark. And today I have Dr. Noble with me, and I'm thrilled to be able to talk to her about everything that you need to know about perimenopause. Dr. Noble, thank you for joining me today.
Of course, it's a pleasure.
Could you please tell us a little bit about your background and how you got into the medical and health field for women?
Sure. I've been a practicing gynecologist for over 20 years, 2 decades. I did a fellowship in minimally invasive gynecology and have focused on gynecology, over the last 20 years. I'm based in Portland, Maine, but I certainly have roots in New York and, a network that, spans the whole country. I'm really interested historically in how we've managed perimenopause and menopause, and sadly, we have not done that well, especially over the last 20 years. I've been in the business long enough to know that medicine often responds very reactively and in a pendulum. And sometimes, and I can think of multiple examples in other areas of medicine where this is true, but in the 90s, about 40% of women were on hormone therapy. And then when the WHI came out in the early 2000s, unfortunately, it was really misinterpreted, or I could say just really limited in what was looked at. So it wasn't clear at that time that there was a big difference between women starting hormone therapy around the transition into menopause in that first year, first few years after that menopausal transition, versus if they came into the clinics and they were, say, 60, 65, and we were to start them then. And I was practicing in the 90s when we did that, and we thought that hormone therapy was the best thing since sliced bread, even if you were in your mid 60s or 70s. So the origin of that trial was really to determine if that was helpful and preventative for cardiovascular health. And what we found from looking at that data was that actually, if started late, that actually increased the risk of heart attack and stroke in the first 6 to 12 months. And there were some small associations, and these were always quite small, but they were kind of blown out of proportion by the media. And physicians became really reactive when they thought about this breast cancer risk. So that risk of breast cancer was identified in women using oral estrogen and progestogens for combination hormone therapy. And that relationship was actually really quite small. It was like an additional 1 in 1,000 women per year. And that association really only seemed to hold after about 4 to 5 years of use. But it was reported in the media as doubling the risk of breast cancer, going from 1 in 1,000 to 2 in 1,000. And people simply didn't understand that. And physicians were very kind of risk averse. And we live in a very litigious society. So there became this massive discontinuation of hormone therapy that really prevailed for the next 2 decades. And because of that, there was this downstream impact in kind of education, time spent on menopause, awareness, limited research and resources. So we were left for about 20 years with people thinking that the safer thing was to not use hormone therapy. Now, reanalyzing that data and multiple other studies have shown that it's actually very, very different to use hormone therapy, whether it's combination hormone therapy when we have a uterus or whether it's estrogen alone, if it started closer to the time of that transition. Yet it's more complicated with increased risk if started late. So there's now kind of a timing hypothesis and understanding that it's very, very different to start hormones early, in a way, kind of continuing with hormones rather than starting them late. And that's where we're kind of at in a nutshell now. I would say the other things that have happened in the landscape is women have become much better advocates for themselves. We have many other things we're doing, multitasking, caring for aging parents, children, careers. Life, I think, has become more complicated, number one. Number two, we're not willing to just stand for these short answers of like, there's nothing to do about it, just suck it up and you can handle this. This is a natural process. Now, I'm a big believer, and you should do what you feel comfortable with. For some people, it is a natural process, and there's no reason they can't age normally. However, there are actually consequences of making that choice in the sense of our bone health and cardiovascular health. So, in a perfect world, in my practice, I would want every woman to know, transitioning through perimenopause and into menopause, that there are tons of options. It should really be individualized to what your individual symptoms are, your risk factors, your family history. and really your philosophy and your preferences. And that there is help for so many of these things, even in very complicated circumstances. Say if someone has high blood pressure, or even if they're a smoker, and even, in scenarios where they've had an estrogen sensitive cancer, years ago, there's also kind of very, you know, I would say complex options that even include local vaginal options. So no one should have to suffer from vaginal dryness, pain with sex, and urinary changes that have resulted from that menopausal transition, because we have options locally, vaginally, systemically. We've got non-hormonal options that impact some of the mood symptoms people can get. We're now aware of all the systems in the body that are impacted by hormones, including joints, brain, vasculature. So I just, my mission, and Let's Talk Menopause's mission, is really to improve awareness, to empower people. It's all free, this information. We understand that there are really complex issues in healthcare delivery and the economics. Many people don't have coverage or have limited coverage and access to experts. In addition, we have a real access problem throughout the US that just finding a physician that's appropriately trained to help you can be really challenging. So my mission would be getting more and more information out to people, understanding there is help. There's a huge range of symptoms that people experience, that if you're concerned and you have cyclic symptoms, it could really be suggestive of some hormonal perimenopausal changes. And it's really quite likely that we can help you with that. I guess that's a long introduction, but
I
that's,
like it. No, that was great. There's so much to unpack here. So I would really want to dive into this. So when it comes to perimenopause, I've talked to a lot of different doctors that some say to wait until you're 12 months, no period, before you start HRT. Do you believe that that's the case, or do you believe that you can
I
start
would say that
earlier?
is decidedly not the case.
Mhm.
And whoever feels that that's the case is unfortunately not understanding kind of the concepts. There's absolutely no reason for someone to suffer for a year without hormones. And understanding the way hormones work and the way the timing hypothesis suggests that it's not great for our body to go through these periods with no hormone and then restart hormone. So intuitively, it doesn't make sense. And I think, unfortunately, this speaks to that lack of education, that lack of time spent in residency, the time pressures on physicians, whether that's a physician that's, say, a general practitioner or an internist or a family practice person. There's no reason to wait for that definition. The time to treat women and to help women is when they have symptoms and when they want to be treated.
And let's talk about the symptoms, right? Because the symptoms I feel like can range from everything from tinnitus to frozen shoulder to hot flashes. Like there's a huge wide
Absolutely
range
right.
of things. Yeah.
A
What do you usually see?
huge. And, it's mysterious to even really well-trained physicians, because people can have palpitations, people can have, new onset migraines. I've seen people sent to ophthalmology for dry eye. I've seen people going from specialist to specialist to specialist. And unfortunately, if they don't have that appreciation, they might not have a primary care doctor that recognizes that either. That's why I tell women, be mindful that if you're experiencing something like this that's new in your 40s, that happens to be cyclic in nature, it's likely perimenopausal and hormonal in nature, at least a part of it. So another good example are exacerbations of skin issues like psoriasis, eczema, new onset hives, allergies, but we can see GI symptoms. We can see many of the ones that you mentioned, as well as significant increases in mental health issues like anxiety, irritability, anger. One thing I hear more lately are people articulating, I don't feel like myself, or they feel that they can't really kind of control these swings. And it's absolutely hormonal swings. And that's why even the definition of perimenopause is the years around this menopausal transition. But I'll often explain to my patients that if anybody's ever experienced some PMS symptoms, some bloating or breast tenderness or irritability or that kind of routine PMS people can describe, cravings, what happens in perimenopause in all those years is these peaks and troughs, these peaks and valleys become more exacerbated. So when we might have kind of done this and tolerated it reasonably well, we start doing this. And that's why we then see that end organ, or like our skin, our eyes, our brain, migraines, because we're having these huge hormonal shifts. And that is absolutely something we can treat and override in various different ways. The vast majority of times, even with other complicated medical issues, we can usually come up with a lot of strategies. And sometimes the first one we pick isn't the right one. Maybe someone has new symptoms from that therapy. So it really does need to be individualized, and again, needs to be informed by their past medical history, their family history, and what they want and what they don't want. I have patients that say, full stop, I never want an IUD. I'm like, okay, we'll go on to the next. But because some of those progesterone IUDs are so incredibly helpful for bleeding issues, I'll often say, I understand that. And I understand that you feel that way, but do you mind telling me why? And I'll sometimes push it a little bit more because oftentimes we have these black and whites and we think, I would never do, say, somebody might say, I would never do antidepressants. And I'll say, okay, but do you understand that maybe they work in a slightly different way here? And so the more options I have that I can partner with the patients and the more things that I can explain so they understand why this might be different than even their experience as a teen or maybe their experience postpartum. These are a lot of times where the more options I have, the more likely I am to be able to tailor a management strategy for then and there. And I also explain to people it's longitudinal, it changes over time. It's going to change in your journey and in your trajectory. And you might be in a very new and different phase, say in menopause.
Hmm.
Whereas in perimenopause, we have, in many ways, perimenopause is actually more challenging to treat because of these hormonal ups and downs. But you might be feeling in a different way, and you might have different symptoms that you might be more open to treating that at a different time. So I just try to be, really inclusive about options, really respect the person's wishes and preferences. I think we all have kind of no-go places, and that's okay too.
Well, I really wish I would have met you when I was in perimenopause because it took me a journey of five different doctors to
I know. I'm
finally get
sorry. I
hormone
hear that all the
replacement. And
time.
it's and when I talk to women, my story seems to be similar to theirs of either being turned away because my blood work wasn't within a certain range, or my periods were still irregular, or no one could trace my lack of sleep. That's a big thing, right? My
Yeah,
sleep was so disturbed, and so it was never traced to any kind of hormonal change that I was going through. So
right.
what type of tips do you have for women?
And there's so much there that, I'd love to dive into. I imagine we could probably talk for hours, but even that kind of misunderstanding about labs, for the most part, labs and serum testing is actually not helpful because, as you found, it can be so misleading. It wasn't in a certain place. Well, if I just described, you could be up here and down here one day to the next. People can feel really gaslit. They can be told your hormones are completely normal when clearly they have not been normal. There's no reason to wait that period of time. And when you touch on sleep, sleep is incredibly important to kind of our mood, our metabolism, our functioning, our brain fog. All of these things are so interrelated. And sadly, I hear that literally every day I'm in the office that I wish I had met you sooner. People are told that either this is all normal and they should just suck it up, or, you know, what do they expect for, say, a person of this age? I mean, I hear so many just unfortunately really horrible things said to people that they either should or could. I often tell my patients when they say, what should I do? And I say, in this area, there isn't really a should. There's rarely a should situation. If I have somebody who has, incredibly high risk factors for osteoporosis and they don't want to do hormones, I might spend more time getting towards that should. I might say that, unfortunately, if you don't decide to do something now and you have real significant increased risk for osteoporosis, I'm afraid we will miss this window. So there are times where I'll sometimes push a little bit more, but otherwise it should be open to all these possibilities and what feels right to you. And I'm a big believer in those trials. If we try the first thing and you say, this is horrible, this is worse. When people ask me, what are the side effects? And I'll tell them the side effects are supposed to be that everything feels better and nothing feels worse. That
Right.
would be, I try to hit it right the first time.
Amazing. All right. Thank you so much for being with me today, Dr. Noble. How can women find you, reach you, follow you?
Well, you know, that access that we talked about is
Mhm.
so sad because I know even in my own practice, people often wait 6 or 9 months, which is completely, you know, Unacceptable, really. And healthcare in this country, I have a master's in healthcare science delivery and economics. It's so problematic, right? So I think that's part of this desire to help launch this Let's Talk Menopause. I'm committed to this as, a free resource for anybody. We put out a lot of content, a lot of information. We partner with really responsible people, and it won't lead people to any weird places. It's not going to try to sell you anything. I think that's one other piece I'd leave people with is there are a lot of people profiting off vulnerable people and what I call kind of menoprofiteering. Anybody who's trying to sell you stuff, if they're subscription services, if they're custom compounded things, these are all really ethically dubious. So I think pushing back that a lot of these places are making a buck off people and they're getting them to do labs and custom compounded. You should not need that. You can go to menopause.org, which is also the National Society, the Menopause Society, and find a certified menopause provider in your area. So anybody who's done that certification can actually, they're likely to be well versed at this, number one, and have an interest and a passion. They might not be a good fit for you either. So it's not a guarantee, but that's a way either through letstalkmenopause.org or menopause.org where you can find certified providers in your area. That's probably my best advice. And
Right.
then reading content and trying to stay away from the things that are selling you stuff and look for kind of free nonprofits and good content and information.
Wonderful. All right. Thank you so much for joining me today.
You're so welcome.